Okay. Hi, everyone. My name is Katie Olsen, and I'm going to do a short overview of opioid use disorder. So first, what is opioid use disorder? The definition from the DSM-5 says a problematic pattern of opioid use leading to significant impairment or distress. And just to note, it's now called opioid use disorder, but we also commonly hear people say opioid abuse, opioid dependence. Both came from the DSM-4, and then also we talk about opioid addiction, so all kind of covering the same thing. So for the prevalence of opioid use disorder, in 2019, there was 1.6 million Americans, and this is a little bit lower. Actually, in 2017, it was 2.1. So that's good, but what's not good is only 18.1, this is percent, received medication-assisted treatment. So it's a really low amount that are actually getting help with this issue. And then also in 2019, nearly 50,000 people in the US died from opioid-involved overdoses. So that's a big number that we can work on. And you can see on the graph on the right, the opioid overdoses over the years. You can see it's gone up a lot. And especially we can see it's gone up in these synthetic opioids, specifically fentanyl is a really big one. And then you can see down at the bottom some of the prescription opioids and the heroin that aren't as high, but they're still elevated and have gone up over the years. So some of the things you can look for if somebody isn't necessarily coming in for this reason, although I found so far, most of our patients come in asking for help, but things you can kind of be aware of that you might see is what's called track marks, which is scars from using IV drugs. And sometimes if people are intoxicated, they can have pinpoint pupils, drowsiness, slurred speech. You can do lab testing. There's the common urine drug screen that we do that can test for opioids, other drugs. It can be important to realize like what other drugs they're on with opioids because they can have a synergistic effect, which can be dangerous. And then we can also look for other markers of their health, like their blood count, if they have endocarditis. These are kind of, progressive health problems that have happened because of the drug use. You can also screen for hepatitis and HIV, other STDs, tuberculosis, just because they're at risk of these illnesses or complications as well. And then there's also the liver and kidney functions that can get affected from chronic use. So for your patients, when you're thinking about who you might end up helping when they have opioid use disorder, this graph kind of shows the demographics. And it's interesting to note that there's a huge majority. It's not like totally spaced out. The majority of patients will be white. There's, more males than females, although that's closer to being equal. And then most of them on here is young, although this is a graph of non-elderly adults because there is also a big problem with elderly adults, but that's kind of separate. So here it's interesting to see that young people make up a really large amount of people with opioid use disorder. So there's different types of opioids, and this is kind of like a brief history of when you're talking to patients and asking what their drug of choice is and kind of understanding their journey of like how they got here, what kind of drugs are more common. So originally back in the 1990s was when there was increased opioid prescription. And then by 1993, they were seeing a lot of increase in overdose deaths. And at the beginning, that was mainly the natural or the semi-synthetic opioids. Then by 2010, they call it the second wave. There was an increase in overdose deaths involving heroin. And sometimes the trend they were seeing is that people who originally had prescription drugs that they ended up using it appropriately, then when they were unable to get those is when they switched over to heroin is a common path you see. And then by this third wave that began in 2013, we're seeing a significant increase in overdose with the synthetic opioids like fentanyl. And this is a big problem because those are many times stronger than the other opioids. And so sometimes people don't realize they're getting fentanyl, or sometimes when people are coming out of the prison system and they've lost some of their tolerance, then when they take fentanyl, they're at high risk of overdose because of how strong those drugs, those synthetic drugs are. So the exact diagnostic criteria, which it's not, I mean, mostly people will know if they have this problem and they're coming because they really want help, but you're kind of looking for if they, so you need to have at least 2 of these just for, you know, documentation, but if they're taking larger amounts or over longer periods than what was intended, if there's this persistent desire and they're unable to control it anymore or cut back, if they spend a great deal of time trying to get opioids, they have cravings, if they're like starting to fail in their life, you know, have these problems in their life at work, school, or home, and then if they're, you know, continuing to use drugs, even though they realize that these are social problems caused by their opioid use, or if they are giving up things that used to be a part of their identity, they're using opioids when it's physically dangerous, and if this is causing psychological problems they're continuing to use, or if they're exhibiting tolerance or withdrawal. So those will probably be pretty easy to identify with patients. And then treatment options. So there's the main 3 are buprenorphine, methadone, and naltrexone. So some of the general points about them, I'll go into each one in a little more detail in a second, but buprenorphine and naltrexone can block the effects of other opioids that people take concurrently, which can be important for people who are at risk of kind of just having times when they're using other drugs again, other opioids, you know, whether it's like socially or they're just unable to like stop themselves from using again. Whereas methadone doesn't do that. They all reduce cravings, so that's good. And then naltrexone can't be used by pregnant women, so it's just important to know. So into each one in more detail. So buprenorphine or Suboxone, it's considered safer than methadone for overdose risk. Oops, sorry. Because it's only a partial agonist, so it's gonna have less of the effects like the respiratory depression. And some people prefer it to methadone because you don't have to do a daily treatment. It can be, you know, a little bit more spaced out, not any more than a month. And usually you start with really close appointments and then are able to space it out more to monthly over time, but that can be nice to have a little bit more flexibility. And then there's also other buprenorphine options like long-acting injectables, but usually people are taking either tablets or there's a film in this photo here. Then there's methadone. You have to go to a methadone clinic and you go daily. And so that may be hard for some people, but also some people really like the accountability and kind of the routine of it. Methadone is a full agonist, so it has slightly higher risks of overdose though. Then we have the naltrexone, or the injection is called Vivitrol. Naltrexone can be both oral or injection, and the oral tablet is taken daily, whereas the injection lasts a whole month. And one advantage is it's not a controlled substance like the other 2 are, and so any provider can prescribe it and administer it. And that makes it easy just for accessibility. And then it also has no abuse potential. It is an opioid antagonist, so it's not activating any of the opioid receptors. And it's actually really nice to see we've had quite a few patients who are having on the Vivitrol injection monthly, and they really like it. So that's been really cool to talk to them about that. So kind of a future outlook. You can see in this chart, first off, that this red line with the heroin overdoses has gone down. This is kind of a while ago, and you can see that concurrently, you know, buprenorphine patients are going up, methadone patients are up and kind of stable. And so it's looking like this is really working, and it's just important to get more people aware of the treatment options and how much it can help patients prevent overdose or just prevent people from, you know, losing so much, because the overall goal of treatment is to return people to productive functioning in their family, workplace, and community, which is why we usually recommend, medication assisted treatment is only part of the treatment. They really need more help. They need to have a social network, they need to have support, they need to probably go through therapy, because they have to also rethink what they want their life to look like and what choices they want to make. Opioid addiction can really vary for different people, but and they can last at different amounts of time, but the goal is really just to return people to their lifestyles. So that is the end of the references. I just want to say it's been interesting to see patients kind of on different parts of this journey here. We have some patients who have either been on Suboxone for a really long time and are stable. We have patients who are on the Naltrexone injection, and that's been really great for them, and they tried that after trying Suboxone and found it a better option. And then we have people who are first coming in and just even starting the process of saying, I have a problem and I need help, and I've heard that there's medication assisted treatment. And so it's interesting seeing the different steps along the way and things that might be an issue for people as they figure out what's best for them next. So that's all. Here's my references. Thank you. And you can email me any questions if anyone has any.
Yay!
Bye.
So I have a question. You can
Let's
stop
see.
recording if you
Yeah.
want.
Let's see where the.
What are the